Okay, so thank you all very much for taking time out of your very busy schedules to participate in tonight's Total Health Conferencing special on updates from the 2021 San Antonio Breast Cancer Symposium. My name is Mark Pegram. I'll be your moderator for tonight's session. I'm a medical oncologist at Stanford University in Palo Alto, California. Next, I'd like to have each of our panelists introduce themselves. First, beginning with our patient advocate tonight, Sheila McGlown. Can you please tell us a little bit about yourself?
Hi, I'm Sheila McGlown, and I live in the St. Louis, Missouri area. I am a 25-year Air Force veteran, and I have been living with metastatic disease for 12 years.
Thank you for joining us. Really appreciate your input tonight. Next, it's my pleasure to introduce Dr. Kristen Whitaker from Fox Chase. Kristen.
Hello, good evening, everyone. My name is Dr. Kristen Whitaker. I'm a breast medical oncologist at Fox Chase Cancer Center in Philadelphia.
Fantastic. And finally, Sunil Badve from Emory. Sunil, how are you this evening?
I'm a professor in pathology here at Emory University and vice chair for cancer programs. I've been privileged to be part of the ECOG-ACRIN group for the last 20 plus years. And so I do have a fair bit of understanding about clinical trials.
Fantastic. Thank you so much for joining us for today's session. I'd like to jump right in, maybe just kind of go around the group here, just ask you your initial impressions of the San Antonio Breast Cancer Symposium this year, just at a high level. Was it, revolutionary? Was it evolutionary? Just out of curiosity, Sunil, what did you think? Were there practice-changing events in your mind, or was this more of a just kind of an update and longer follow-up type symposium overall?
I thought more of the latter, but although not to undermine the importance of the latter, that is, it's clearly important to have long-term follow-up data on a lot of the trials, and a lot of the data that we suspected was going to be showing the way it showed. So there were no surprises, which is always a good thing. Kristen, your thoughts?
So often with long follow-up, sometimes we do see surprises where results don't hold up in the long run, or maybe the survival curves come back together with long follow-up, that sort of thing. So I agree with you this year that even though many of the presentations were longer follow-up type studies, at least they didn't undermine the original interpretation of the data set when it was first presented. And when you see patients on Monday, that's really a big deal to make sure that the practice that you've been doing, especially if it's based on newer data, that it's holding up. I mean, over the years, we've seen even withdrawals of approval from the FDA. I'm remembering like the bevacizumab days, et cetera. So it's another recent example, of course, is atezolizumab in first-line triple-negative metastatic breast cancer. First, it was approved by the FDA, and then when the confirmatory trial didn't come in positive, suddenly it's withdrawn, and that changes practice. So we didn't see any big negative results, in my opinion, this year. So that's reassuring. Kristen, what did you think overall, just general impressions about the meeting at a high level?
Yeah, I mean, I think I agree with you guys. I think the last few years we've had such exciting results from, some of these, especially HER2 positive, studies. I don't think we got that as much this year, but I do think we got really important updates. And I also think we got really important kind of proof of concept research presented this year. So I think there's some exciting things in the pipeline. I think we just have to kind of continue to do the studies and kind of wait for some of the later phase trials to give us more information.
We got spoiled for the last probably 2 or 3 years with so many new drug approvals in the metastatic disease setting. I guess that's not sustainable realistically forever. So this is probably one of those years where, we didn't see a lot of brand new data that will lead directly to an FDA indication, et cetera, but nevertheless important. And sometimes evolutionary advances are along a critical path to practice-changing activity. Sheila, any idea? I know you didn't have a chance to go to San Antonio this year, but what's your take on just the flow of information in general in your circles. What have you heard from your constituents about San Antonio this year, if anything? I know it was difficult because not very many people attended live, frankly, but what's your take on the meeting overall and the flow of information out of the meeting in this COVID era?
Well, we did a couple of advocates we're working on is the maximum tolerable dose necessary in clinical trials. So we did have a poster there, which was interesting because they lost it and then they found it. But that was exciting to see that our poster was accepted, and there were a lot of questions about it.
Fantastic.
But the patient advocates that were there and that attended virtual, they were excited about it. And we're always excited about, San Antonio, especially metastatic. Well, I guess any breast cancer patient, just to see what's going on with the latest information and medicine that's going on.
Well, congratulations on your poster presentation. I'm very pleased to hear that. That sounds exciting. I know that with targeted therapeutic strategies in the modern era, oftentimes we don't need to push all the way to the maximum tolerable dose, because as long as you have that target kind of covered from a therapeutic point of view, if you go any higher than that, you might just introduce more toxicity and there might not be any therapeutic gains. In fact, you might take a step backwards if there's too much toxicity from off-target effects. So that sounds like a really important message. Well, let's jump right in then, shall we? I'd like to begin tonight's discussion just with the topic of diagnostics. I saw a lot of papers this year in particular about different diagnostic modalities in metastatic disease, but early stage disease as well. So Sunil, I'd like to begin with your take. Some of the information that was pretty interesting was regarding circulating tumor DNA. And there are lots of different assays out there. Some are ultra sensitive and are used in the early stage disease setting to determine whether patients might have minimal residual disease that's not clinically measurable, for example. The Natera assay comes to mind in that regard, that is highly sensitive. I think it has like about 100,000-fold sequencing depth that are private to just that individual patient's common mutations, about 16 different genes in that particular assay. But I also saw papers on follow-up of metastatic disease to see response, and correlates with imaging studies. And then finally, I saw some interesting data on therapeutic target identification. In this case, mutant estrogen receptor in a background of wild type receptor. You can see the onset of the mutation and then adjust your treatment accordingly. Can you tell us a little bit about ctDNA technology and where we're at now, and when should we expect to hopefully replace CT scans of the body for assessment of response, for example? What do you think?
So I think first thing, I'm not sure whether we can replace CT scans or PET scans because they are very targeted and they identify the location. So ctDNAs are a good harbinger of adverse prognosis. I think that's the better way of looking at it. You see it, you expect bad news to come up, start figuring out where the deposits might be, and maybe more frequent imaging, or hopefully in the new data will show that treating early might be beneficial. But right now we are at a stage that we know that bad news is coming. And clearly what we are increasingly understanding is presence of circulating tumor DNA mutations is bad news. Whether it's the earlier you detect it, the earlier the metastases are likely to happen. The longer you survive without the circulating tumor DNA, the better it is. And once you see it, we can't really predict whether the metastases were going to be manifest in 2 months, 6 months, or 9 months, but we know that that train is about to arrive. And that is kind of what I gathered from some of the presentations on ctDNA. What I found particularly interesting was with endocrine therapy. The ESR1 mutations, if they are present, there seem to be a resistance to aromatase inhibitors, and having that kind of information early on would enable patients and their physicians to choose the appropriate therapy, which in this case would be a SERD, that is fulvestrant, or one of the other estrogen receptor degrading molecules that are coming along. And there are many of them that are in the pipeline, some more developed than others, but clearly that seems to be the way to go. Also, there's plenty of data to suggest that ESR1 mutations are very rare in the untreated patients. Less than 3 to 5% of patients might have them, but they jump up to 20 to 30% in patients treated with AIs. So clearly that seems to be a mechanism of resistance. Obviously, it would be fun to know what exactly causes the resistance, how it causes, what are the pathways activated. All of that information is still yet to come. But at least from the observational point of view and from the treatment point of view, we know that this is bad news if you're using AI. Switch over as quickly as possible. And that switch seems to benefit. That's where we have data for. At least that's my understanding of it. I would love to hear what you guys think as oncologists of the data.
Dr. Whitaker, I mean, Sunil made an excellent point. Obviously, we're not going to replace CT, body imaging, PET, et cetera, wholesale, because location is important, admittedly. But in as much as some of the ctDNA assays are quantitative and reflect tumor burden overall, could we maybe replace at least some of the restaging intervals for metastatic patients in follow-up, and thus cut back on the need for imaging, which has, radiation exposure associated with it? CT contrast, is uncomfortable because it causes burning sensation, et cetera. And the second question is, after that, and what Sunil mentioned about the PADA-1 trial, could you tell us about that trial and how ctDNA can be used to identify a therapeutic target, indeed, and what the outcome was? So if you could tackle both of those questions, that would be great.
Sure. So, I think we're not there yet with ctDNA in terms of kind of maybe even replacing some of the imaging. If you looked at some of these different studies that were presented, it seems like there's still some variability in terms of the sensitivity of the different assays. There's a lot of question about, should we really be looking at kind of ctDNA as a qualitative measure or as a quantitative measure to really help us kind of guide our clinical decision making. So I think we're not quite there yet. I think that's definitely the direction we're moving in. I mean, that's the ultimate goal. Can we do something less invasive and maybe more cost efficient, for our patients with metastatic disease, especially? I actually thought the PADA-1 was probably one of the more interesting studies that was presented at San Antonio, just because I'll tell you, as a breast medical oncologist, I've really been dying to get more information about kind of the clinical utility of some of this ctDNA. I mean, I think it's something that we hear a lot about, and I think we all can agree that ctDNA, to Sunil's point, has relevance as a prognostic marker. But, I think we also are really trying to move beyond just understanding that when you have positive ctDNA, you have a kind of poor prognosis related to that, to really being able to use this information also to be predictive in terms of us understanding, what treatments are actually going to help patients or how we need to modify treatment. So, PADA-1, essentially what they did in this study was there were patients who were metastatic, hormone receptor positive, HER2 negative breast cancer patients. Interestingly, all of these patients had to have received a CDK4/6 inhibitor to go onto this study. So really kind of trying to get at this unmet need that we have for patients who have progressed beyond CDK4/6 inhibitors, to kind of address that need there. So essentially all of the patients had to have CDK4/6 inhibitors as previous treatment. They initially were treated with an AI plus, why am I blanking on their combination?
Palbociclib.
So they initially were giving palbociclib plus an AI, and all of the patients had their had ctDNA performed to look for these ESR1 mutations. And like Dr. Badve said, for kind of baseline ESR mutations, it's low. Only about 3 to 5% of patients in the study had it, but the patients continue to get ESR1 mutations detected through ctDNA. I think they checked it at like study enrollment, and then again at 1 month, and then I think every 2 months for like a year, monitoring the patients. And essentially, they saw that kind of as the study went on, I mean, they moved from about 5% of patients having positive ESR1 mutations to closer to about 25% of patients having positive ESR1 mutations. And what they did, interestingly, in the study, they said, well, let's see now that we have this ctDNA kind of rising levels of these ESR1 mutations, let's see if we have corresponding changes in kind of their disease burden in these patients. So essentially, they restaged all these patients with scans. And for the patients that actually did not have progressive disease at the time of those restaging scans, they were switched from palbociclib plus an AI to instead to palbociclib plus fulvestrant. So essentially, what they showed in this study was that by switching these patients early at the kind of detection of these new ESR1 mutations, that they actually more than doubled the progression-free survival, median progression-free survival in these patients, which was a great finding. But, you know, I think it kind of raised some questions about really what is our kind of ultimate goal for our patients? Is it just, you know, improving median PFS, or is it really overall survival? And I know that was kind of a lot of the questions that came from the discussion of this poster was, can we really say because we're delaying, you know, progression that we're actually helping our patients in the long run? But it was a really interesting study, and I think it kind of leads us to think, you know, there probably is going to be a role for using ctDNA to kind of help guide our therapy in the future.
HADA-1 was over 1,000 patients. Is that enough to change practice today? And if so, you know, who's going to do the sequence analysis? Is this going to be a commercial source? Is it going to be part of the Garden 360 assay? Or, you know, in terms of practicality, where are we headed? Are there going to be, you know, ctDNA assays that are only for the estrogen receptor in these types of patients to expect in the future?
So I would say I don't think we're there yet in terms of kind of changing practice based off of HADA-1, although it's, you know, it's a significant study, you know, size, but I think we're not quite there. You know, Dr. Badve, I'd be really interested to hear kind of your take on kind of how easy it is to actually do this analysis and to use these assays in kind of routine practice if one day we're saying, yeah, we are going to be doing this for our patients routinely.
So, I mean, the simple part to it is that you're just collecting a tube of blood. Okay, so from the patient and the clinician standpoint, this is a very easy test to do. From the analysis point of view, most academic centers do have the ability to do NGS. Now, whether they do it in-house or send it out for these kind of specific mutations, many of the academic centers now also have partnerships with established large-scale providers. And those partnerships will also assist not only looking at one mutation, but multiple other mutations and help us understand what are the additional mechanisms of resistance that might be involved in addition to ESR1. So clearly, there are advantages to bringing assays in-house. You probably might get it done a little faster, but the bandwidth of doing the bioinformatic analysis, the bandwidth to add new assays quickly is much, much better in the commercial enterprises because that's what they do for a living. They're doing 1,000 of these tests a day. And so they can have 20 bioinformaticians poring over the data and doing large scale panels to monitor every little things that is changing. So, and that's where a lot of us in pathology are struggling in terms of how much NGS do we do in-house versus sending it outside. There are clearly benefits of sending it outside. However, there are also drawbacks in terms of turnaround time, in terms of education of next generation of physicians. You know, there's always those kind of issues. So it's a very difficult question to give a straightforward yes, no answer. It depends on the institution where you are, the relationships that exist, and of course, the science that you are trying to push. So CDK4, just one last comment. CDK4/6 inhibitors, as you know, they are associated the RB status and cyclin D and cyclin E and all of these data that are coming up about what are the targets of CDK4 apart from CDK4 itself, and what are the mechanisms of resistance. If you're doing a panel assay, a broad-based panel, you might get some insights in that too. So clearly there's a lot to be gained and a lot that we don't know. But this is a space that one would watch very closely to figure out what the mechanisms of resistance are. Sorry, Mark.
Sheila, I know you've had to go through, these types of body imaging, CTs, maybe bone scans, maybe PET CTs. What's that like, and how thrilled might you be to be able to replace those, at least some of them, in the future, if this comes to fruition? Would it be better in your view to just go to the lab and get a blood test, or do all these imaging studies? What is that like for you?
I would rather just get a blood test. I've been on a clinical trial now for 3.5 years. And at first, when I started off, I was getting scans every 6 weeks. So it's just like, can we make this easier?
Yeah.
And that would be great, just to, even if I can go to a hospital over here just to get, where I live at, because I'm like 30 minutes away from the cancer center where I go to, which is not far, because some people have to drive farther than I am. But and just to get a blood test and not have to go through the just the CT scan process, the anxiety and everything else that comes with it, that would be great. I would love it. But then they changed it to every 3 months, which is, was good for me. But yeah, just to get a blood test, or just send a nurse to my house, to get a blood test, that would be great.
Now, let me ask you this. Do you get your scans typically all on the same day? For example, if you're going to get CTs and a bone scan, or do you get are they on the same day, or are they on different days because they're different departments? Or do you do a PET CT, which is just one scan? What do you typically?
No, I get them different days.
Different days even. So that's even more of a nuisance. Like every 6 weeks or every 3 months, you're not just going once, you're going more than once to different departments.
I call it cancer center my second home, because I'm always there. Like I'm literally always there getting a scan or something. And it's just like, man, can we just make this easier for the patient?
Exactly. If it's like my cancer center, you're probably trying to find a parking space half the time. So let's move on then. Another exciting technology that I noticed at this San Antonio was, sort of a single cell immunophenotyping, if you will, in a tumor mass to try to predict immunotherapy response. I know there are new technologies that have been published, some from my institution, on using metal ion conjugated detection antibodies called MIBI. Yep. Another one is using DNA barcoded antibodies, where you can use maybe 50 or 100 different antibodies all at the same time in the same experiment and get entire immunophenotype repertoires within an entire tumor all in one experiment. And you can not only do it at the time of, let's say, diagnosis, but you can do it following treatment as well, because the immune infiltrating cells are dynamic. They can come from the peripheral blood into the tumor, or presumably the opposite direction as well, maybe go to another metastatic deposit, et cetera. Where are we at with that, and what did we see at the San Antonio, Sunil? Anything promising? The other thing is our limitation right now for immunotherapy in triple negative disease has been this frustrating PD-L1 expression issue, and you can't convince me, and I'm curious to see what you think. I don't think PD-L1 is the answer for immunotherapy response in triple negative breast cancer. I think it's going to be something a little bit more sophisticated than that. And what's your take? And do any of these technologies have promise to break through to the next level on that issue?
So let's start with PD-L1. It's an assay that everybody loves to hate. And the reason is fairly simple. It's a complicated assay that requires one to look at the tumor cells and the immune cells. So you're looking at two different compartments. And most of the classic assays that we have been doing, ER, PR, and HER2, you look at field after field and you get more or less similar results across multiple fields. PD-L1 is very heterogeneous in expression pattern. So that's a reason we have to look at each and every field of the tumor. And sometimes if you have a 2 centimeter or 3 centimeter tumor, you're looking at 100, 200, 300 fields to try to get an estimate of what's going on. Typically, if you look at 20 fields or something, you get a good estimate, but still it can be troublesome. Obviously, if you have a small biopsy, you can look at the entire biopsy, but there may be variability between a biopsy and an excision because you're looking at smaller and larger amounts of tumor. So that's one part. And of course, the consistency between pathologists suck. Having said that, it is the best assay that's available to date. We know that patients who are PD-L1 negative are very unlikely to respond. Patients who have less in breast cancer, the data presented shows that if you have a PD-L1 CPS score of less than 10, the response rate, whether you measure it at progression-free survival or overall survival, that those rates are comparable to no treatment at all. Beyond the 10% mark, you start seeing response rates. So clearly, it's the best assay that we have. It's not the greatest since sliced bread, and clearly we hope for improvement. What are the alternative assays? One of the alternative assay is, of course, tumor mutational burden. That is, how many mutations exist per megabase of DNA. And this is a state, you can measure it from 0 mutations per megabase to 100 mutations per megabase, and those kind of scales. And different institutions have different cutoff points where they call something hypermutated or not. But in this particular San Antonio, there was a data that was presented about hypermutated tumors that were HER2 negative. And in these tumors, there was clearly some benefit from PD-L1. Obviously, this was not a large trial. This was a phase 2 trial. So we have to kind of interpret the data with caution. But at least we now know that there may be an alternative test that might come along. The problem, of course, is TMB, that is tumor mutational burden, tends to be very low in breast cancer. Again, less than 10% of patients tend to have a high TMB phenotype. So question that comes up is, yeah, it might be good for a select population of patients to identify those patients, but PD-L1 positivity, if you take a 1% cutoff, almost 70% or 75% of patients are going to be positive. If you use a 10% cutoff, it's around 40% of patients are going to be positive. So clearly there are differences between 10% of positive assay versus 40% positive assay. So TMB is likely to miss a fair number of patients. And so as much as we all dislike the PD-L1 assay, it's at least the current method for detecting immunological risk or selecting patients for immunotherapy. The other aspect that comes along is, and as you rightly pointed out, there are multiple assays that are coming along the pipeline to detect multiple proteins at the same time. So when we do the traditional immunohistochemistry, we are looking at one protein at a time. And we don't get an idea about what is the relation of that protein or those cells that are positive in relation to other cells that are present within the tumor or within the tumor microenvironment. The ability to do multiple stains at the same time or multiple protein detections at the same time clearly gives you a lot more information as to what is positive, where is it positive, what is the interrelationship between each of these markers. And as we have done that with RNA, we have done that with DNA for some time, but the ability to do with protein is relatively new. And as you pointed out, the MIBI assay is one such development. Obviously, Gary Nolan from Stanford has done multiple such discoveries and patented many of these assays or these types of assays for multiplex analysis. So this is an area of huge interest. And there was a study that utilized mass spectrometry, where basically you take the protein detecting antibodies and tag them with rare metals, and then you throw them all in the same bunch on the tissue. And then depending upon the binding, you kind of know where it is located and how it's, what is the level of that protein and what are the interrelationships. And as you start looking at this, you can get data from 20, 30, 40 proteins at the same time, even 100 proteins at the same time. And analysis of that data is obviously difficult, but we get the right team together, you get a lot of information, and you can do the pre and post biopsy or pre and post treatment biopsies and get a valuable data as to what the possible mechanisms associated with response and or resistance are. What we have now beginning to see, the first kind of data from a fairly large series of patients, is that response to atezo was related in some ways to Ki67. There were also, in patients that were resistant, there were a lot more macrophages than CD8 positive cells. So there are these emerging relationships that we are coming to get to know and understand, that these relationships are also as important as just presence or absence. Clearly, we function differently in different environments. And right now we are presenters, and 5 minutes from now, maybe we'll be listening to people. The same way these proteins act in concert, and depending upon the environment they are present in, you can get a response or lack of response. So clearly, extremely important area, and we will see a lot more of these types of assays in the next ASCO San Antonio meetings as they come along.
Great, thank you very much for that comprehensive response. We're getting a couple of questions from our viewers. The first two are for you, Sunil, and then one from for Kristen will be after that. The first two questions are, Garden provides tumor mutational burden readouts on their assay. Would you tailor therapy based upon a rising or falling TMB trend in an otherwise clinically stable patient? The second question is, does the CPS result change over the course of disease response or progression? And do we need to measure that multiple times? And a corollary to that question is, do you need to measure it in different metastatic sites? So I'll let you tackle that. And Kristen, the question to you will be the update on Keynote 355 and the different cutoffs for the CPS score in that update. Now we'll get to that right after Sunil tackles this other.
So starting with PD-L1, because that's an easier question for me as a pathologist. PD-L1 does change in expression. There's enough data to show that that happens. Clearly, there are organ sites that have associated with less immune response and less PD-L1 expression. Classically, liver is one of those sites where the immunological response is poor. And so since we are measuring the the PD-L1, not only in tumor cells, but also in immune cells, there is a major difference in looking at liver metastasis versus other sites. There are some differences between primary tumors and metastasis, but you have to remember that when the clinical trials were performed, they were using whatever samples available. That is, if there were primary available, they used the primary. If there were metastatic samples available, they used the metastatic. So ideally, one would take the sample that is closest to the current therapy. But if you don't have a biopsy taken in the recent times, you can use an older or original tumor sample without any hesitation. And those were the criteria that we used. Now, the question of rising ctDNA is a much more difficult one. I wish we had the answer, but I don't think the answers are clear-cut as yet. And again, I would pass it to the oncologist to comment, but as far as I know, the data is very limited. So what we see is increasing numbers of patients turning positive over a period of time, but higher level of ctDNA may not necessarily reflect that the patient is likely to develop metastasis sooner, or present with metastasis sooner, I should say.
Kristen, what are your thoughts on that issue? Certainly if somebody has a, negative tumor mutational burden report and then later has a positive one, I suppose we could act on that since it is approved in terms of FDA regulatory approval for immune checkpoint inhibition in breast cancer. And then number two, could you just quickly update the Keynote 355 data that was shown in San Antonio?
Sure, yeah. I think like Sunil said, I think right now we have pretty limited data on kind of how we should be using changes in tumor mutational burden to really guide changes in treatment. Again, I think this is an area of great interest. I think there will be a time where we have more data to say, yes, we should be changing therapy. And if we do change therapy, this is kind of the direction we should go in, but I do not think we're there yet. And then, Keynote 355, the updates for this study, unlike what we saw kind of with Impassion 130 and the atezolizumab data, we see, like we talked about in the beginning, that we continue to have positive findings from this clinical trial that were really kind of confirmed in this updated analysis. So if you recall, essentially, Keynote 355 essentially gave randomized patients to either receiving chemotherapy of kind of the physician's choice, which normally were taxanes versus carbogem or treatment options, or randomized to also receive pembrolizumab. And when we looked at that data, we saw kind of at the initial point that patients who received the pembrolizumab had a improved progression-free survival and also improved overall survival. And, I think in terms of those two data points, we really didn't add too much new data. I'll tell you the numbers. For this updated analysis, they said that there was a 27% reduction in risk of death for patients who had the pembrolizumab added in this group. When we look actually at the median overall survival, we see that patients who received pembro had a median overall survival of 23 months, whereas patients who did not receive pembro had a median overall survival of 16.1 months, so about a 7-month benefit with the addition of pembrolizumab for overall survival, which is a significant finding in my opinion. And then we see for the kind of updated analysis for median PFS, it was 9.7 months in the pembro arm and then 5.6 months in the investigator chemo choice arm. I think one of the big updates that kind of came from this study was really looking at the cut point for the PD-L1 expression. So we know that currently we have pembrolizumab approved for patients who have a CPS score of equal or more than 10. But actually in Keynote 355 during this conference, they presented data on patients in 2 different cut points. So one was patients that fell into the group of a CPS score of 1 or greater, or patients who had a CPS score of 10 or greater. And interestingly, what they found is that for those patients that did not have that cut point of 10 or greater, they did not get that benefit from the addition of pembrolizumab. So it really kind of confirmed that our cutoff point should in fact be 10 or higher, which is what we currently use to support the use of pembrolizumab.
I see, thank you. We did see some new therapeutic agents at this San Antonio, which I thought were pretty exciting, even though they may not be, registrational intent just yet, although one of them is phase 3. But let's talk next about the Tropion study of datopotamab deruxtecan, or Dato-DXd, a TROP2-directed antibody drug conjugate. It seemed to have activity in triple-negative breast cancer. Kristen, can you comment on that study? And do you think there's a path forward? I mean, we already have a TROP2 antibody drug conjugate. Do we need another one with a different payload, do you think?
Yeah, so I think these initial findings from this study actually were pretty exciting in that what they demonstrated was that patients who had actually received a prior TROP2 antibody drug conjugate, for example, sacituzumab, there was a proportion of the patients in this study that had received, one of those agents previously, and they still had about a 34% overall response rate. And the rates were even better in patients who, again, they still were heavily pretreated patients with triple negative breast cancer, but in the group that was heavily pretreated and hadn't received a previous TROP2 or TROP2 antibody drug conjugate like sacituzumab, they had even a more impressive overall response rate. I think it was around 52% in that group. So, you know, I think sometimes we do feel like in kind of the area of kind of treatment that maybe we get a little crowded with kind of multiple agents in that same category. But I think that this study is showing you that maybe there is room for multiple antibody drug conjugates, and that potentially there may be a role for sequencing some of these agents. And I think that needs to be investigated more.
What about the tolerability of that agent? Did it seem like it was clinically feasible to give?
I think in general, yeah, it did. I think from what I'm remembering in terms of the toxicities, I think there were some GI toxicities, but overall, it was pretty well tolerated medication.
Okay, very good. Now, another agent for which there was phase 3 data at the San Antonio's elacestrant, and this is one of the orally bioavailable selective estrogen receptor degrading agents. And this phase 3 trial was this oral SERD elacestrant versus investigator's choice of endocrine monotherapy for ER-positive, HER2-negative metastatic disease, the so-called EMERALD phase 3 trial. Kristen, can you summarize the top-line results from that study? And do you think that this phase 3 result might be enough ammunition to go to regulators for a new drug approval?
Yeah, so essentially in the EMERALD study, they looked at, again, patients who had prior progression on CDK4/6 inhibitors. I think this was a theme we saw in several studies. I mean, this is an unmet need in breast cancer where we have these patients that have developed resistance to CDK4/6 inhibitors. They've now progressed, and now we're really trying to define an effective therapy for them as kind of next line of treatment, second line for most patients nowadays. So essentially in EMERALD, patients were randomized to one of two options after progression on a CDK4/6 inhibitor. The novel option here was the elacestrant, which is the oral SERD that Dr. Pegram was just mentioning. And then the other option was for the patient to go on Faslodex, or I think an AI. So another endocrine monotherapy essentially was the other option. So essentially what they found is that when patients were treated with elacestrant, they did have an improvement in their median progression-free survival compared to fulvestrant. But the reality of kind of these findings was that the median progression-free survival in both groups was quite dismal. And that kind of was my biggest take home. So I think, you know, we see with fulvestrant that you have about a 2-month median progression-free survival. I think this might have been a little bit closer to 3, something like it changed it by about a month. So it was a very minimal kind of change in the median progression-free survival. But that being said, I do kind of take away from this that this was an interesting proof of concept in the sense that it's a new kind of area of development with these oral SERDs, which, you know, I think for many reasons, an oral SERD would be preferable to fulvestrant, where you have to come in for your shots. But I guess we have to kind of look at cost, which we don't know at this point, but it would be nice for patients to be able to have an oral therapy they can take rather than a shot. But I think what this study really demonstrated is that we continue to need agents in that kind of second line space after CDK4/6 inhibitor progression, and that those agents are probably going to need to be a combination therapy. So I don't know that I think that we're here yet where we're going to see just an oral SERD being enough for these patients. We probably need an oral SERD plus another targeted agent. So I think that's the space where we really have to kind of investigate moving forward.
Great. Sheila, I don't know if you're familiar with fulvestrant or not. It's an injection that you have to take in the gluteus muscle on both sides once a month. And this new drug class that we're talking about, the oral SERD drugs, you know, could potentially replace the need for this intramuscular injection with a syringe. What's your take on that? Have you ever had that drug? Or
Yeah, I was on it for like 3 years.
Yeah. How
Yeah.
was that in terms of tolerability? I understand patients after a long period of time on that drug can get, sterile abscesses in the gluteus muscle from multiple injections. It can be painful, et cetera. Can you tell us about that? And what do
It
you think
wasn't,
about replacing that with a pill someday?
well, that would be nice, but it wasn't bad. My nurses would warm it up before they gave me an injection, but it wasn't too bad. I think that because I had to take it, I think I endured, what I had to endure to stay alive. So yeah, I was on it for like 3 years, and it's a beast because them needles long. But if I could just not just take a pill, but if I could just take a pill, that would be great as well. So
Right. It's really
I think
exciting.
anything that makes it easier for the patient, I'm all for it.
And then it's particularly exciting for this new drug class. If successful, it could open up a whole opportunity for early stage breast cancer in the adjuvant setting, where really it's not feasible to give fulvestrant for 5 years, or sometimes in some cases even 10 years, where we give adjuvant endocrine therapy deliberately. And so that's a whole new area where this drug class could really make a difference if it's superior to our current endocrine adjuvant therapies. So that could be pretty exciting. Kristen, I'm seeing a lot of these drugs: elacestrant, amnicestrant, giredestrant, camizestrant, LY348356, and we worked at Stanford on a phase 1 trial of G1T48. Which one's going to be the winner and why? Care to speculate?
I don't know that I can speculate. I don't know that we know, the answer to that. I mean, Emerald obviously was the first phase 3 study that kind of reported out on one of these agents. I think in terms of kind of dosing, they seem to have kind of similar dosing schedules. To me, there's no reason to suspect that one would be dramatically better than the others, but I think we have to see the results of the studies and kind of truly take it from there.
What about toxicities and safety signals from these drugs? I'm seeing a lot of, for example, in the elacestrant, I'm seeing, nausea. For the AZD compound, I'm seeing like visual disturbance, and for the Genentech compound, I'm seeing diarrhea. A lot of kind of unusual, and for the AZ compound, there was bradycardia. So a lot of unusual kind of toxicities that I didn't anticipate from an anti-estrogen. What's your take on that? And do you think some of these adverse event profiles might distinguish one oral SERD from another? What's your take on that?
Yeah, I mean, I think absolutely that the toxicity profiles may be kind of the distinguishing factor, similar to kind of what we see with some of our CDK4/6 inhibitors. They can sometimes have a little bit different toxicity. And I think, when we look at those toxicities as we continue to study these drugs, I think that's also going to dictate kind of where we use these medications in the breast cancer kind of sequencing of treatment. So, we may be willing to accept a little bit more of those in a patient who's metastatic, and we say, well, we have limited treatment options, and we're trying to kind of do everything to prolong your life. Whereas a early stage breast cancer patient where we've told them this is curative treatment, and they could potentially take letrozole and have it be pretty well tolerated, or oral aromatase inhibitor, and not have some of those toxicities, then maybe kind of the adjuvant setting isn't going to be the right place for some of these medications if the toxicities are really going to be more significant.
And what about combining the oral SERDs with other agents? I mean, so often now we're seeing fulvestrant, our current available SERD in the clinic, we're seeing it combined with a lot of other things. We're seeing it combined with CDK4/6 inhibitors, seeing it combined with alpelisib, the PI3 kinase inhibitor, and so on. Do these toxicity profiles bode well for combinations of oral SERDs with other agents, or are some of these going to be deal breakers? Like, let's say diarrhea, for instance. If you want to combine, abemaciclib with a oral SERD, and they both cause diarrhea, is that an issue, do you think?
Yeah, I think we're absolutely going to see that kind of with some of these combination treatment options that we may try to put forward, that toxicities are going to be kind of the rate limiting factor in terms of whether we can use this in patients. I mean, I think all of us that treat breast cancer patients know, I think of alpelisib as one of the most difficult drugs to kind of keep patients on in a metastatic setting because of toxicity. So, I mean, if you're already having a medication like that can cause some GI toxicity, and then you potentially add in an oral SERD that also has that may really be a rate limiting factor, and it may be the reason why that combination doesn't necessarily move forward, kind of in the future. So I think we're definitely gonna have to look at toxicities very closely in these combinations.
Right. Thank you.
One of the things I understand about SERDs is that they bind to the estrogen receptor and cause a conformational change that causes the receptor to be degraded. So we don't exactly know how each of these compounds cause the conformational change and what the end product of those is. And maybe that may be the reason why there are different toxicities, because it's like poking someone and getting them to kind of alter a pose. And if you're poking at different spots and different places, you might get different reactions, ranging from a smile to a smack in your face. So that may be one of the reasons why we are seeing different toxicities with different agents, because there may be also a little bit of off-target effect, or once a conformational change occurs, the protein might bind to other binding partners that it may not bind normally in a breast epithelial cell, but may bind in a GI tract, or may bind something in the heart where the other proteins are overexpressed. So clearly we need to have a much better idea of how exactly these things work. It's different in different, it's likely to be different in different cells. And maybe that's where the answer lies as to which one might be successful.
These oral SERDs all have different routes of elimination and different metabolites too. It could be that some of the toxicities are due to metabolic byproducts. We don't know that yet. A good example of that is in the case of PIK3CA alpha selective inhibitors. Alpelisib, one of the other issues other than hyperglycemia is cutaneous rash, but we see that the Genentech, alpha selective PI3 kinase inhibitor doesn't seem to cause as much cutaneous rash. So that may well be a metabolite of the alpelisib that you don't see with a different drug with the same target, for example. So we're getting some other interesting questions for you, Sunil, in the chat here from our viewers. One is this issue of changing therapy based on increasing ctDNA levels. This gets back to that idea of, could we theoretically one day in the future, not now, I agree with everyone tonight that we're not going to replace CT scans yet, but that would be a, one possible therapeutic ideal in the future. They're saying that since we don't use markers like, CA2729 or CEA or CA15-3, we don't use those to make therapeutic decisions alone. We get CT scans instead and use RECIST criteria to make therapeutic changes. Are we going to do the same thing with quantitative ctDNA? Like if we have stable levels for a long time, I suppose, couldn't we replace interval CT imaging if it's stable or lower? But if it goes up, then we probably would still need imaging to confirm it. Is that your take?
I guess so. I mean, we really don't have any data. The closest thing we have is the good old SWOG SO500 trial, where they tried to do something similar, but using circulating tumor cells. And in that trial, as we all know, the patients were basically metastatic breast cancer patients who had circulating tumor cells. Those were randomized to continue to receive the same therapy versus receiving another form of therapy. And in that, we didn't really see any difference in terms of outcomes. Of course, there are many arguments as to why that trial failed to show the differences, including maybe perhaps it was underpowered to notice the differences. So the same thing exists today about circulating tumor cells. We really don't have, circulating tumor DNA. We don't have adequate data to suggest that that is a good strategy, that increasing levels indicate presence of metastasis or impending detectable metastasis. There was a British study that was presented which showed all sorts of variations that one can imagine in terms of circulating tumor DNA over a period of time. Yes, it is bad news, but the levels tend to wax and wane with different therapies, with different conditions. So at least as of now, the jury is still out whether you should treat more aggressively if the ctDNAs are high, or B, you should treat with the goal of decreasing the tumor DNA burden that is present in the blood. So we really have to watch the space. Next year, perhaps the year after, we'll have that data.
Yeah, I think, we've learned something from other solid tumor types in this regard. There was a Nature Medicine paper from our institution, Asher Lizaday and Max Dean, in non-small cell lung cancer, looking at a technology at Stanford called CAPSEQ, and they showed that quantitative lung tumor ctDNA tended to correlate with imaging outcome for that disease. And then there was a paper about a year or so ago with a Natera assay, again in solid tumor malignancies, looking at response to immune checkpoint inhibition using their ctDNA assay, and it seemed to correlate with radiographic findings in that smaller study as well. So there may be a story here. We will need a lot more data to get clinically validated data to be sure before we go making substitutions for CT. So that's the key point for Monday morning in this case. Next, I want to shift gears a little bit and go back to Kristen. We saw a very long follow-up now, 12 and 13-year median follow-up for the soft and text trials. What's your take on that? And is there anything there that's new, or does it just reinforce our current practice? And the same for the responder trial data. Anything there that surprised you at all?
Yeah, I think for soft and text, what we've seen with longer follow-up. So when they looked at, I think it was the 7-year follow-up initially, they were actually showing that tamoxifen plus ovarian suppression therapy was outperforming essentially an AI, so exemestane plus ovarian suppression therapy in terms of overall survival. So we saw with this recent update that was no longer the case. The other thing that we saw, and I think that this study just kind of confirmed, is that if you compare patients that receive ovarian suppression therapy, regardless of whether it's an AI or tamoxifen, they do better than patients who do not receive ovarian suppression therapy in terms of recurrence risk, but also overall survival, which is more important. But again, I think, the study still emphasized the point that it's really the selection of the patients that we have to kind of, look at here in terms of our high-risk patients. So ovarian suppression in our higher risk young patients absolutely is still beneficial from the soft and text updates. And then for RxPonder, I don't think we saw too much new, but I mean, I think that what we saw was that we still have this great debate of whether or not in these premenopausal women that now, RxPonder is looking at premenopausal women with an oncotype score between 0 and 25 that had between 1 and 3 positive lymph nodes. We still don't quite have the answer of whether or not this the potential benefit of chemotherapy. So it basically showed that even women who have an oncotype score between 0 and 25 benefit from chemotherapy. But the big question is, do they benefit from chemotherapy because chemotherapy is causing ovarian suppression, or do they benefit from chemotherapy because of actual cytotoxic effects from chemotherapy? So it was a big debate during San Antonio. It was a nice kind of debate that was an hour-long session that kind of went back and forth. But I'll have to tell you, I mean, there's strong arguments in both directions. So I feel like for me on Monday morning, kind of based off of what we know from RxPonder and soft and text, I don't feel comfortable yet saying that in my young premenopausal patients with oncotype scores between 0 and 25, that I would just forego chemotherapy and instead give them ovarian suppression. I think that was kind of my biggest take home, but I think it is a great debate, and I think there are kind of arguments to be made on both sides.
I think I have to agree with you. There was a lot of presentations about CDK4/6 inhibitors in metastatic disease this year at San Antonio. A lot of updates. I didn't see much that was new, maybe a few subset analysis. From ESMO, we saw the ribociclib first-line data in combination with AI and a survival benefit there. Did that change your practice regarding the selection of first-line CDK4/6 inhibitors, or are they all the same? And we'll just have to wait for the OS data from the competition. What's your take on that?
Yeah, you know, of the CDK4/6 inhibitors, in my mind, abemaciclib is kind of the most unique or kind of different as opposed to palbociclib and ribociclib. You know, maybe partially because of the dosing schedule, but also I think it just acts differently, you know, kind of on cancer cells. So when I saw the updated overall survival analysis, it does actually push me a little bit more towards using for first-line patients ribociclib plus an AI. You know, I mean, I know we've seen now with Paloma that we didn't see that same overall survival benefit in the first-line setting. Abemaciclib now we're seeing some of that same overall survival benefit. So it does push you a little bit away from the palbociclib as a kind of first-line treatment choice, although it was our first CDK4/6 inhibitor. But I think the challenge with all of these studies is that it's always very, very hard to do cross-trial comparisons. And I think that's one of the big take-homes when we think about these studies. You can't really do cross-trial comparisons, and there may be just very kind of finite or kind of unique differences between the patient populations that actually can contribute to why we see some of these differences in terms of overall survival, especially. And I think the verdict is still out. I think a lot of times with our hormone receptor-positive breast cancer patients, we need longer follow-up to truly see overall survival. So it could be that we may have that data come years from now.
You know, the statistical power for the OS endpoint in those first-line CDK4/6 inhibitor trials was not as high as the power for the primary endpoint of PFS. So it could be that by play of chance, you might expect that some of the trials will come in positive and the others negative, just because, you know, we didn't have adequate statistical power. Plus, we need to be cognizant that different studies may have different crossover frequencies that might contaminate your overall survival endpoint. So that'll be critical if you're going to try to compare, you know, one or more trials against each other. Sheila, have you ever had a CDK4/6 inhibitor like palbociclib? You know, the brand name is Ibrance, and the others are abemaciclib, and the others ribociclib. Have you ever had any of those?
No, I'm HER2 positive, ER/PR positive.
Okay. You know, it's interesting, Sheila. You know, there are starting to be There's starting to be studies now of CDK4/6 inhibitors even in HER2 positive disease, but that's still a research in progress. There's a study called the Patina trial, for example, that's looking at HER2 positive first-line metastatic breast cancer. And those patients usually are treated with a chemotherapy drug called a taxane in combination with 2 HER2 antibodies, which I'm sure you remember are pertuzumab plus trastuzumab. And in that recipe, oftentimes patients will you know, get to a point where they can't tolerate the chemo portion anymore, but they're still doing really well. And so they can be maintained, if they're ER positive also, they can be maintained with hormone therapy plus the 2 antibodies. So the Patina trial is looking at that maintenance phase where they would nowadays be getting endocrine therapy plus the 2 antibodies in a maintenance fashion after finishing their chemo, and they're randomizing them to get a CDK4/6 inhibitor or not. So that trial is finished accruing. It's a phase 3 trial, a registrational trial. It'll be really interesting to see when that study comes out, if that's of any benefit, even in the HER2 positive space. Next, I want to move on, but staying in the same theme, the general theme of CDK inhibition. Kristen, we saw data on a CDK7 inhibitor that looked pretty intriguing. Samiracyclib. I can't pronounce all these new drugs. Samiracyclib. Can you tell us about that? And were you interested? Do you think that might have a future home in breast cancer? What was your take on that data?
Yeah, so again, very similar to elacestrant data, I think that the data from this study on the samraciclib is very nice proof of concept. I think there was only about 30 patients in the study that were reported on, but essentially it looked at the combination of samraciclib plus Faslodex. Again, you're hearing me say it again probably for the third time, really looking for better treatment options than just Faslodex in patients that have progressed on a CDK4/6 inhibitor. So in this study, 100% of the patients have received a CDK4/6 inhibitor as well. And when they progressed, they were giving samraciclib plus Faslodex. And essentially what they found with this study was that patients who received this combination certainly had improved median progression-free survival. They actually showed the waterfall plot where many patients in that study actually had very significant and durable responses to the samraciclib. And, you know, some of our data that we have kind of in this second line setting, things like the SOLAR-1 trial, which looked at Faslodex plus alpelisib, when they actually kind of compared the median progression-free survival we see, for example, in SOLAR-1 compared to what we see in samraciclib plus Faslodex, the patients that were treated with this new agent, samraciclib, which is a CDK7 inhibitor, had a prolonged median progression-free survival compared to those other patients. I wanted to see if I had some of the numbers here for you.
Yeah, I have a clinical benefit rate that is no progression at week 24, 6 months, of 36%. So
Yeah.
that waterfall plot, now it's a small study, non-randomized, you know, lots of caveats here, but for a new agent in this space to have such durability, even if the response rate itself isn't astronomically high, the durability sure seems to be there. So it looks like it has promise, especially maybe in earlier lines in the future, hopefully.
It definitely looks promising. And I think I saw this agent, I said, you know, what they're seeing in the data on some of the oral SERDs and now seeing the CDK7 inhibitor, I said that would be a nice treatment strategy for kind of a combination strategy to investigate further. Oral SERD plus maybe the samraciclib, maybe we can get even better response rates, clinical benefit rates, and things like that with that combination.
Better
the
than
one thing that
combination. Yeah.
Yeah, and the only other thing I was going to point out about that, just because, you know, I think we really are moving into this era where it's extremely important when we develop these new agents that we also be able to identify what patients are going to respond. So really the patient selection. So I do think, again, this was a small study, but this study actually did look a little bit at, I think it was also ctDNA, where they looked at mutational profiles to see if they could find any kind of mutation that identified who responded and who didn't. And not completely surprisingly, they found that patients who had TP53 mutations really didn't get any response to the samraciclib medication. So kind of playing into that idea of let's make sure we can really kind of identify biomarkers or who responds to these new agents as we continue to develop them.
Right.
Just a quick comment along those lines. We are really bad at that. We are good at selecting patients who might respond, but we don't really understand mechanisms of resistance to the extent that we should. I mean, I don't need to talk about the HER2 mechanisms. Mark has done a yeoman's amount of work about resistance to HER2 mechanisms were postulated, and there are at least 10 different mechanisms that could be possible. The same thing with CDK4/6. We know it works in some patients, we don't know why it works, but we are happy it works. And the question basically is how do we supplement additional therapies that could block downstream pathways and try to understand what's going on. And that has been a major trouble in pathology part of it, in biomarker discovery. And coming back to the point that Mark made earlier, that these multiplex analytic technologies that are coming up that not only allow you to detect the presence of a protein in the tissue, but its locations, its relationships with each other, those kind of technologies are going to be phenomenal in understanding mechanisms of resistance. And so I would watch that kind of space very closely to figure out which combinations might be the better ways of going forward. And maybe it may be marker A positive, marker B negative, marker C positive kind of group. So just like we talk about triple negative patients now, ER positive, ER negative, PR negative, HER2 negative, and treat them separately. We may have to kind of identify subsets of patients that are positive for markers, a set of markers, and negative for a set of markers, and then say, these are the patients who are most likely to respond to a particular combination of drug. And that would be a really great way of going forward.
So Sunil, for years, medical oncologists have conspired to try to get rid of pathologists by embracing increasingly more sophisticated technology. But you'll be pleased to know that I think we're a long way from there yet. We'll need your help for a while yet.
Well, so, when Oncotype came, there was a comment about the microscope with a stop sign on it. And 20 years later, we are still practicing, and our role is increasing even more.
I see the microscope in your Zoom video feed.
Yes, it's right here.
Yes, exactly. So now staying on this topic of target expression versus therapeutic response, the HER2 paradigm started out that one of the mechanisms of resistance, if you will, to HER2 targeted therapy is absence of the target. So HER2 negative patients didn't respond well to trastuzumab, whereas HER2 positive patients did respond well. It was pretty simple back in those days. But now we're seeing, with the advent of new therapeutic strategies like antibody drug conjugates in particular, we're seeing a whole new category of HER2 called HER2 low. Sunil, can you walk us through that? And are we going to be asking you to measure HER2 low now for selection of new therapeutics?
Yeah, I mean, this is a good problem to have. And I'll tell you why I say it's a good problem to have. So classically, we have defined HER2 positive as 3+ protein expression and with or without amplification of the HER2 gene. And with some of the newer agents that have come along, the biosimilars that have come along, what we are noticing, or what was first noticed in preclinical studies, is that these agents work not only on the cell that is actually binding the antibody, but also they destroy the neighborhood. And so there's what they call the bystander effect. And because of these bystander effects, we don't need as much protein to be present on the cell as was originally required for the classic trastuzumab antibody. So as these novel combinations are being developed, we realize that there is lower and lower amount of protein that is necessary. And so there are these trials called the Destiny trials that are showing some remarkable effects. And basically now what we might end up having is these tumors that are expressing what we call the 1+ and 2+ levels of protein. That is, there is some protein, but not very bright. It's not a Christmas tree, but there are some dim parking lights on those trees. Those kind of patients might also respond very nicely to these agents. And that's the exciting part. The other part, of course, is we talked about triple negative patients who are HER2 negative, but many of those patients had low levels of HER2 expression. So even among the triple negatives, we might be able to treat a significant percentage of patients with these novel anti-HER2 agents. The same thing applies for ER positive patients, particularly the high-grade tumors. We have known for a long, long period of time that one of the methods of resistance for endocrine therapy was an upregulation of the HER2 protein. And maybe we might have an opportunity to treat endocrine resistance with some of these agents. So it might be that the HER2 eligible populations might shift from the 10-15% that we have to 50-60% of the patients, just like ER is 70% of the patients. This might be a huge category of patients that we might be able to treat very successfully with these novel forms of agents.
In a recent review paper published in the JCO by Tarantino and colleagues, they suggested that the HER2 low population may be north of 50% of human breast cancer. So this could be a real breakthrough for a lot of patients and a whole new treatment paradigm. So there's great hope for this. Of course, there's an ongoing trial in HER2 low with trastuzumab deruxtecan called the Destiny Breast 04 trial. And that is randomizing patients to trastuzumab deruxtecan versus single agent of physician's choice in this HER2 low population, which are 1 or 2 plus IHC.
And then there's also the trials going on for the ultra low, which is basically, there's just a whisper of little bit of HER2 here and there. It's not completely negative, but there is a dot here and a dot there and a little there. It's nothing like the Christmas tree, but maybe a small little flicker of light somewhere, to use that analogy. And those patients might also, I mean, that is where the trials are going, that we have gone from the Christmas tree down to maybe some lights. Now it's a candle burning in some corner. That kind of level of HER2 positivity might be enough to treat some of these patients. And so maybe in a couple of years, we'll be talking about HER2 positive patients or HER2 eligible patients as being 50, 60, maybe 70%. Who knows? I mean, that's very exciting because a lot of patients will have novel therapies, particularly think about the triple negative patient population, where we have such exciting agents now.
Thanks for reminding me. There's published data from the group here in the Bay Area called Cepheid Diagnostics, and they use real-time PCR to measure HER2 transcript, and they find that, in patients with IHC 0 for HER2 or IHC 1 plus for HER2, their transcript levels are not dissimilar. So even IHC zeros may have some HER2. Certainly at the transcript level, that's true. And perhaps it's at the protein and they're false negatives because all the assays that we're using now were designed specifically to look for high-level HER2 overexpression, not to look for small amounts of HER2. So those trials that are ongoing for the IHC zeros will also be really interesting to see if they're really HER2 low as well.
So for example, if you were to do a frozen section and then cut the section by freezing it and then looking at the protein level, you will find our standard assays will show that those patients are positive. Similarly, alcohol fixation, the reason we banned it is because it starts picking up some expression within the normal breast epithelium. And so we don't know what low is. This is all an artificial barrier that we have created by the way we process tissues and the concentration of antibodies that we use for the detection system. It's like saying we have grass, we have shrubs, and we have trees. Right now, we basically say, if you have a tree, then you are positive. Then we are now slowly moving towards the shrubs, and we're saying, well, if the shrubs are there, that may be positive. And then we are talking about ultra low, which is the grass level, and maybe that might also be enough. And then the question is, how tall is the grass needs to be? Whether it's just above the ground, maybe below the ground, who knows? I mean, that is a whole area that needs to be explored.
Sheila and Christian, now it's time to talk about HER2 positive metastatic breast cancer and San Antonio updates. Kristen, can you walk us through the what I think were pretty exciting data from the Destiny Breast 03 trial vis-a-vis HER2 positive breast cancer brain metastasis treated with trastuzumab deruxtecan? What was your take on that data?
Yeah, so this was actually very exciting data, and I would absolutely say I think this was practice changing and very, very relevant for everyone to know about. So just a reminder of what Destiny Breast 03 was. Essentially, these were patients who were HER2 positive patients who had all received a taxane-containing regimen in the first-line treatment. They were then randomized to TDM1 or trastuzumab deruxtecan. And essentially in this study, we already had seen data that had been presented previously at conferences that showed that the patients who received trastuzumab deruxtecan had an improvement in their median progression-free survival and overall survival. But I think the most interesting results in terms of updates we saw was really that they kind of honed in on some of the specifics of patients with the brain mets in this study. So in this study, there were about 20% of patients that had a history of brain mets and about 15% of patients that had brain mets currently demonstrated on their imaging. And you know what they found in this study, so just giving you some of the important take-home points. So in terms of median progression-free survival, kind of for all comers, for the patients with T-DXd, they had 75.8 months median progression-free survival compared to only 34.1 months in TDM1. So dramatically different median overall survival. But I think more impressively, because it's such an unmet need, is kind of brain mets in this HER2 positive group of patients, we saw that among the patients in this study that had brain mets, 67.4% of them had an objective response to trastuzumab deruxtecan, compared to only 20% of the patients that had brain mets in the TDM1 arm. So dramatically difference in terms of the response rates. And then we also see some data in terms of the progression-free survival to kind of go along with this. So in patients that had brain mets at baseline in the trastuzumab deruxtecan arm, the median progression-free survival was 15 months compared to only 3 months in patients that had brain mets at the time of enrollment in the TDM1 arm. So again, dramatically improved median progression-free survival and overall response, objective response rates in these patients with brain mets. So I think the big take home of this study was, one, we have some pretty good data for patients that have treated brain mets. That's the big kind of key point here. These patients in this study all had treated non-progressing brain mets, which kind of distinguishes it from some of the HER2 client-to-catnip data. But for these patients that had essentially stable brain mets, we see for sure that patients who receive trastuzumab deruxtecan in the second line have an improvement in their median progression-free survival and also in their response rates to brain mets and when they receive the treatment with TDXD as opposed to TDM1. So definitely, you know, the take home, definitely when we're thinking about second line treatment, trastuzumab deruxtecan now outperforms TDM1 without a question, and that's confirmed now in patients that also have brain mets.
Sheila, what does that mean to you and maybe some of your colleagues in the advocacy community who may be affected by brain metastasis to have a new agent with such promising activity in brain metastasis? What's your take on that?
Well, it means a lot, especially for, I guess, HER2 positive patients, because, you know, that's one of the things myself I worry about is brain mets. But I don't know if I could say this, but that's the trial one. And that's the one I've been on for 3.5 years. I was on phase 2 of it, and it's still working. So
congratulations, Sheila. That's great to hear.
I didn't know whether I could say it, but yes. And you know, my doctor introduced it to me, and she said, "This is going to be the next miracle drug." And I'm like, okay. And then I get to San Antonio 2019. It's like, it's been approved, and I'm like, okay. But she kept me on I'm still on the clinical trial portion, which,
Sheila, can I interrupt you there? We are so grateful to you for being so heroic to try something new. I mean, what is that like when you don't know what the outcome is going to be? Just kind of the promise based on, you know, rodent studies and things like that. What is that like?
I didn't really know the extent of clinical trials until my doctor oncologist introduced it to me. And and it wasn't a last resort. I had a 4th progression in my rib. And she said, "Well, Sheila, you know, let's try this clinical trial." And I was like, okay. So she's, you know, I went through the clinical trial process and everything, and had a clinical trial coordinator and everything. And, you know, they sat down and explained to me, you know, what was going to happen. And I don't know, it was kind of surreal at first. And I'm like, well, it's 3 years, 3.5 years, you know. I was like, this stuff is working. So
Well
So,
done.
yeah. So I think just leaving my legacy and helping other women, with just helping other women with the quality of life and different things like that makes me feel good. So,
Yeah, and Sheila, I mean, I think, this is the point I always make to my patients about clinical trials, that every new drug development we had came through a clinical trial. So unless we have our patients that are really like you, selfless in a sense, to participate in these clinical trials, it's impossible to make progress in breast cancer. So we really, really do appreciate when our patients participate in clinical trials, and we hope that you get benefit from it too.
thank you. Yeah.
And the good news is with this latest data cut on Destiny Breast 03, we're still not seeing grade 4 or grade 5 interstitial lung disease outcomes with longer follow-up now. So that's also very reassuring. Our time is about up. Let me just mention in passing here, and maybe Kristen, you can weigh in, and then I'll go once around the group and give you each about 1 minute to make final comments. But there was a phase 2 study for tucatinib in patients with leptomeningeal metastasis, and that had some intriguing results as well. And even though it's a small study, it suggests that there may be some activity of tucatinib in this patient population. Kristen, were you impressed by that data, and would you use tucatinib in somebody with newly diagnosed leptomeningeal spread?
Yeah, so unfortunately, it was only 17 patients. I think the study ended up getting closed when tucatinib was approved, it sounded like, but it was a small study, but absolutely it had promising results for patients with leptomeningeal disease. So I think because patients with leptomeningeal disease really, unfortunately, I think we all know who treat breast cancer patients and see this develop, they have such a poor prognosis. They have such rapid development. We really don't have very effective treatment options for them. Just off of this limited data, I actually would feel comfortable giving a trial of this to my patient that's HER2 positive with leptomeningeal disease. And I hope that we see kind of larger studies to maybe validate this, so we really have a little more evidence to justify this treatment choice and make us feel more confident in kind of its benefit.
Our time is up, so let me just go around the room here one last time. Sunil, one paper that was the most important to you at San Antonio, we only have time for one. What would you say was the most pivotal paper from your point of view?
I think it has to be the Destiny trials. I really am very, very enthused by the HER2 low and the number of patients that might be potentially benefit from these types of agents. And really, I'm very impressed.
Kristen, what about you? One paper.
It sounds like I'm following behind Sunil, but I was absolutely going to say the Destiny trials too. I mean, I think Destiny Breast 03 to me really was the most practice changing, and it really does address such an unmet need, and that's our patients with brain mets and HER2 positive disease. So absolutely phenomenal results, I thought, from this study, and I'm excited to see it in this drug in other spaces, I should say.
I'm going to go with Esperant and the Emerald phase 3 trial, just because it's the first oral SERD to make it to phase 3 in the metastatic setting. And my excitement there is it holds such great promise for opening up the adjuvant setting one day in the future for an oral SERD approach, if these metastatic trials prove successful, and if this drug as a class is well tolerated. Sheila, since you are the most inspiring amongst the panelists tonight, having literally lived through many of the topics that we discussed today, I'm going to leave the last word for you. What can you tell us? What are your hopes for the future? Do you have any recommendations for us as practitioners in the field? What can we do better? I'm giving you the last word.
Thank you for all you do, and just continue. Just know that we as patients are partners, and that we work together to stay alive. And just thank you for just caring and just treat me as an individual and treating my treatment as an individual, because as you know, breast cancer, we're all different, but just being, trying to improve the breast cancer community. And I truly, truly appreciate it, because 12 years later, I'm still here. I was diagnosed de novo, but my mom, she was diagnosed and it spread to her lungs, and she only lived 3 years. So right there tells me that research is winning. So thank you.
Sheila, you are an inspiration to us tonight. Thank you. And thank you for being so heroic to participate in clinical trials. That wraps up our session this evening for What to Do on Monday in the wake of the San Antonio Breast Cancer Symposium in 2021. Special thanks to Total Health Conferencing for all their logistical support, for providing all the background details and video support for tonight's discussion. Dalen Miller at Total Health was also invaluable to us. Thanks to her in making this broadcast possible. And finally, special thanks to our sponsors tonight who helped support the proceedings. That is Daiichi Sankyo and Pfizer, allowed for an unrestricted educational grant to Total Health to make this evening possible. Thank you all for taking time again out of your busy schedules. Thank you for your interesting questions and comments in the chat. We really appreciate your participation. If there's anything we can do to help you take care of your patients in the future, don't hesitate to reach out to any of the faculty panelists or to Sheila tonight. And thank you all very much. Have a great holiday season, and we'll look forward to seeing you in the new year.
Thank you.
Thank you.
Thank you.